Okay, now I'm recorded. Okay, so health promotion and maintenance, you all know this, right? We need to stay in shape to prevent stroke or even cardiovascular disease. Light to moderate ETOH, so we can't have a little. Um, People on birth control pills or even estrogen, like postmenopausal women, they can be at increased risk for stroke. Okay, and everybody should maintain proper weight and should not do cocaine, methamphetamine, illicit drugs. Okay, because they can lead to stroke. Cocaine and methamphetamine, especially because it causes hypertension, and that can cause like a brain bleed. All right. So the warning signs, we use BFAST is probably the easiest thing for you to remember. So if somebody's having a stroke, one of the important things that you do as a nurse is recognize those cues, right? That they're having a stroke. In most hospitals, you call a code stroke or a neuro code, depends where you work. So balance, loss of balance and headache and dizziness could be a sign. The eyes, so sudden loss of vision in one or both eyes, some drooping of the face, weakness on one side, and we're going to go into that a little deeper. Speech, so patients could either have trouble forming words or understanding words, and then call 911. So if it's embolic or hemorrhagic, it's going to be sudden confusion. Thrombotic, it may be a little bit slower onset. All right. So your assessment. So we're not going to go into the stroke scale because I don't, that's a little too much for you. I just don't want you to know this. When you think somebody is having symptoms or somebody presents to the ED, the assessment needs to be done within 10 minutes, the neuro assessment. And then a CAT scan without contrast is done within 25 minutes. Okay, so a non contrast CAT scan. The reason they do non contrast is because contrast shows up as white on a CAT scan, and this is just interesting. You don't have to know this for the test, but so does blood. So they do a non-contrast to determine if it's hemorrhagic or ischemic, because that's going to determine the temperature. Not the temperature, the treatment that is given. Anybody that has a change in their LOC, you should get an O2 sat and a blood sugar, because your brain runs on sugar and oxygen. And if they are having a problem with one of those things, if you put oxygen on or get them some glucose, it could improve, right? Sometimes people with hypoglycemia can present and shock like. So you'll get a history, get the timing, and these are just the herbs. I'm going to go to the right versus left-sided stroke. Okay, now I said this the other evening, and this is important for you to understand. I was talking about traumatic brain injury, and it really doesn't matter what the injury is, okay? But if a patient has an injury on the right side of their brain, they're going to have pupil changes in their right eye. So ipsilateral pupil changes. That's what we call that. So on the same side as the brain injury or insult, okay? And then they could have hemiparesis, which is weakness on one side. They'll have that on the opposite side. So if I have a right-sided brain injury, I'm going to have left-sided hemiparesis or hemiplegia, and hemiplegia means half your body is paralyzed. Okay, so that's what it means. So on the contralateral side is how it's going to be presented, and there's quite a few questions about contralateral weakness. So just know the pupil change is on the same side as the brain injury, whether it be stroke, TBI, TIA, it's going to be on the same side. So the pupil changes are on the same side. The weakness or paralysis is on the contralateral side, which is opposite. So that's important. All right. So There are some differences between left and right hemispheric brains. I'm not going to go too deep. I'm going to tell you like the really important things, okay? So with left hemispheric CVA or stroke, all right, CVA stands for cerebral vascular accident. Um, then the name has changed to stroke, but I noticed your book uses both names, and now the name is trying to transition to brain attack to bring more attention to how important it is. Okay, so people that have left hemispheric strokes, they um, have aphasia. They have like all the A things. Aphasia means they can't speak anymore. Now, usually they can understand you, but they can't speak anymore. They can't do math anymore. They can't draw anymore. They can't read anymore. So that's with left-sided. Now, left-sided get very angry. They get frustrated easy because after if you lose like your ability to speak to somebody, or you have like weakness all of a sudden, or paralysis would be worse on one side, right? You're going to feel powerless, and then you may take that anger out on nurses, but try not to worry about it too much. Okay. Now, on the right side, I'm going to tell you something that's going to make you remember this. If somebody has an injury on the right side of their brain, they're not right in the head. They get really an impaired sense of humor. They're like really inappropriate. They could just become like compulsive gamblers, or they just are not right. They don't recognize their family members. They can't see faces anymore. They're very impulsive, and they engage in confabulation because they don't remember things, so they make it up. Okay. So the main thing I want to stress with the left and the right stroke is that um, the damage is going to be on one side of the brain, and the pupil changes will be on the ipsilateral, or the same side, and the weakness is going to be on the opposite side. Okay. Now, try not to get turned around in an exam, because you'll get questions like, it'll say, the patient had a left hemispheric stroke. What is the best way to feed them? Right? So if they have a left hemispheric stroke, they're going to have right-sided weakness. And you have to remember that. So you want to place things where they can reach them on the left side. Okay, so just keep that in mind. If they have a bathroom, you want it, and they have a left-sided stroke, that a sorry, left hemispheric stroke, right? So left side of the brain is damaged. The right side is going to be weak. So you want to make sure like their table is on the left side, their phone is on the left side, so that they can use that. In if they have a bathroom, the railing, if they have like a railing, it's on the strong side. Okay, those are some things you have to remember. All right, and then in that same vein, if somebody has hemianopia, and that means they're going to be like this right here. Okay, this person is blind in the left side of both eyes. So if that's the case, if you have a patient that has left-sided uh, homonymous, and that means the same side, hemiopia, you need to make sure you're putting things on the right side of their view so that they can see them, because they're really blind, and they will like neglect anything on that side. Okay, so that's important. Safety first. Right, people with right-sided strokes are a high fall risk. They're both high fall risk, but right hemispheric strokes are a high fall risk because they also lose their balance very easy. Okay, so they need to. This is for scanning the environment if they are blind in half of their eye. Okay, that's really important. So again, you're going to approach from the other side that they have the blindness. So if it's on the left, you're going to approach them from the right. You're going to place things in the field of vision. And then some, like this is the example, somebody with right-sided hemianopsia approach from the left side and put belongings on the right side. Okay. All right. So interventions for aphasia. So Wernicke's, and this might be on your proctor because I noticed it was on your practice A. Broca's area is in the frontal region, okay, left frontal lobe, and Wernicke's is in the left temporal lobe. So Broca's is aphasia. It is, they can understand you, but they can't speak. So we call that expressive aphasia. And Wernicke's is receptive aphasia. So they can talk, but they really cannot. It's like a word salad. Okay. So with Wernicke's, think of word salad. All right. So your interventions for aphasia, just remember the mnemonic PROP. So give them enough time to respond. I know as a nurse, especially in the hospital, you're on a med surg floor, you're like so busy. It's hard, sometimes you're trying to be patient, but you're thinking of all the other things you have to do. So you have to try to remain patient with these patients. Reoriented, give one instruction at a time and use a picture board. Okay, with medications. Okay, I'm going to talk about mannitol because this is, it's always highly tested, right? So you need to, if you're giving it, you're giving it IV, use a filtered needle to draw it up, use an IV filter, make sure it's not crystallized. Now, for you, it's important to remember you need to give it slowly because mannitol is hyperosmolar. So it's going to pull all the fluid from the, like the tissue and bring it into the vascular space. And your patient can go into pulmonary edema during this transition, while the body's diuresing. So you have to really monitor for fluid overload every hour when you're giving it. They need daily weights, never discontinue it abruptly, and then infuse slowly to prevent fluid overload. That's really important. These are just some drugs. Anybody that has any type of brain injury, meningitis, anything that we're talking about that can increase intracranial pressure, they need to take stool softeners to prevent the Valsalva maneuver. That's really important. Okay, these are the two aphasias, and I put it here because I think it might be a proctor topic. This is Broca's area, and it's in the motor, right near the motor region in the frontal lobe. Speech is slow and broken. That's how you can remember it. All right. And then Wernicke's, this is the receptive. So yeah, here, so that they can speak, but it doesn't really make sense. Okay, so wacky words on word salad is how you can remember Wernicke's. All right. Now we'll go into seizures. This is acute mnemonic. I wouldn't memorize it, okay? Because whatever we talk about, like we're talking about stroke. Stroke patients are going to be prone to seizures because when you have a stroke, the brain cells become anoxic, okay, and that can make you prone to seizures. And then also TBI makes you prone to seizures. Brain tumors makes you prone to seizures. So meningitis is going to make you prone to seizures. So like all the conditions, the brain bleeds we talked about, all those are going to make you prone to seizures. So, and that's what your exam is on. So most, seizure is going to be a topic on the exam. Okay. Yeah. So to the brain, it occurs, could occur due to anoxia to the brain. All right. People with brain tumors have them. Older adults are at risk because of stroke. So, with seizures, okay, so a generalized seizure, when you get, I don't know if you're doing peds first or maternal child in 120, you'll learn more about these absent seizures in pediatrics, okay? I'm going to focus on generalized tonic-clonic seizures or grand mal seizure. Probably what you're think what you think about when you think about a seizure. But if you look in ATI, there's like 5 different types of seizures or something. I'm just going to really concentrate on generalized grand mal seizures, because as a med-surg nurse, that's probably what you're going to encounter the most, and it has safety issues with it. So that's why I'm going to focus on that. Now, people that have generalized seizures generally have some type of aura, and that's an important word for you to know, because it's a sensory warning that a seizure is imminent. Okay, I'm not going to go into petit mal. Status epilepticus, I'm just going to tell you one thing about this. This just means a person is continually seizing and they use some kind of sedation like aprazolam or diazepam. It's and this is why when you have a patient that has had a seizure, you always want to make sure the IV is patent. Okay, that's very important to have a patent IV, because you're not going to be able to put an IV in when they're seizing continuously. Okay, so you want to maintain the airway. Okay, now here's the meat right here, the nursing implications and seizure precautions. Okay, so anybody, again, that you think may be at risk for seizures, you're going to make sure you have airways at the bedside. OA stands for an oral airway, and MP stands for a nasal pharyngeal airway. Okay, you don't insert them during a seizure. Okay, but you may need it when the patient is post-ictal after. So the patient has a seizure, and then after they're very, very sleepy, let them sleep, put them on their side so they don't aspirate. But that's why you need the airway handy. Make sure your suction is set up properly, and I nag about this all the time, but I don't wait until something happens on my shift to see if my suction is working. I always test it when I go in the room after I do my initial assessment on my patient. I check my patient and then I check all my stuff like the IVs, the lines, and make sure the suction is working. Maintain the patent IV. You need to have oxygen ready to use in case they seize, because you may need to put oxygen on somebody, like if they turn cyanotic. And never put padded tongue blades in their mouth, and never insert anything in their mouth. Now, you might have to take one of those skinny suction catheters if you think that they are choking on their saliva, but generally you don't put anything in their mouth. So during a seizure, stay with the patient and call for help. You want to document the time it started, but also what was the patient doing at that time. Make sure you place the patient on the side to protect the airway. And if they're in a chair, you're going to have to slide them to the floor, move all the objects, make sure the environment is safe for them. Place the O2 if you need to, suction PRN, but never put anything in their nose or mouth. And don't restrain. I think you know that, okay? And note what the patient was doing when seizure begins, and when the patient is done seizing, right? You're going to have to reorient over and over, okay? So that's another thing you'll do. So in the post-ictal period, after the seizure, place patient on the side and let them rest, okay? That's important. Your documentation, you can use the mnemonic TDoc. You want to document the type, duration, onset, and complications. Oh, okay, phenytonin. So phenytonin is going to be, I think, if you're going to get asked something on NCLEX or your proctor, phenytonin is going to be the anti-epileptic that you will get asked about, okay? So with patient teaching, you're going to assess if the patient's on birth control pills, because phenytonin and birth control pills don't match. Yeah, they're not good together, right? Because the patient that can make the birth control pills unreliable. It also increases the effects of warfarin, and phenytonin. It's contraindicated with a lot of different medications. So the patient, you need to teach the patient, like, they can't just start a medication. They can't just take herbal medications. They always have to refer back to their provider, okay? They need to take the medicine at the same time each day, and never swim. People that are prone to seizures should never take a bath alone and never swim alone. All right, the side effects of phenytonin. Now remember I said this was highly tested. So hair growth, all right. When I worked in a community ICU one time, when we took care of like little children that were trached because they like maybe had a near drowning accident or something like that, but they would come when they became septic to the ICU, and they were all on phenytonin at that time. It was popular to give it back then, and they had the most beautiful eyelashes. They were very, very gorgeous, but they also had enlarged thumbs. So anybody that's on phenytonin needs to know they need to see the dentist every 3 to 6 months. Nystagmus, that is a side effect, and nystagmus is involuntary eye movements, and we're going to talk about it more because it's also a symptom of multiple sclerosis. Okay. They can get rashes. They shouldn't take it while pregnant, and it interferes with folic acid, so they could be anemic. I'm not really going to say a lot of things about back pain. So back pain is usually due to not lifting the right way, poor posture, carrying too much weight. And as you get older, you get osteoarthritis, or you could get osteoporosis. Now, I did notice that on the ATI practice assessment, they're asking about how to make somebody comfortable when they were having a particular test, like I think it was a CAT scan or something. But what you can do is offer them a lumbar pillow to make them comfortable, because I think you might see that on your proctor. All right, with brain tumors, I'm not going to go into like all this. There's just a few things I'm going to go into because there's like all types of brain tumors, right? And they can have all types of signs and symptoms. I just want to teach you broadly because that's what you need to know right now. So usually people with brain tumors, they have global signs and symptoms, and you can use the mnemonic HAS, and it's a headache, usually in the morning when they're waking up, altered mental status, and seizures. There's the seizures again. Okay, the other signs and symptoms are due to increased intracranial pressure. So they'll have nausea and vomiting, seizures and convulsions, loss of balance, papilledema. Papilledema, the physician would assess that, and that's when um, the vasculature in your eye is swollen. It's not really important for you to know right now, but that's just something the provider does. But this is important. I want to point out something to you. Okay, so this right here is your tentorium, right? And so you draw this little imaginary line, and this is the cerebellum. So anything up here, we call that supratentorial. And then anything in this, below this tentorium is infratentorial. And the reason I'm showing you this and the reason I'm telling you this is because there are some nursing interventions that you need to know if somebody has a craniotomy. So if they have a supratentorial craniotomy, okay, the head of bed needs to be 30 degrees. If they have an infratentorial craniotomy, the head of the bed can be no more than 10. Okay, so 10. All right, so that's important. So after a cranie, you're going to monitor for cerebral edema, increased intracranial pressure. With increased intracranial pressure, you're probably going to get tired of me saying this. Change in LOC is going to be your first sign of increased intracranial pressure. Okay, so they could have a change of their LOC. They may not recognize their family anymore. It's a progression, but change in LOC usually decreasing. They can be irritable at first. Okay, you're going to see some neurological deficits and hydrocephalus. So that's like water on the brain. And I think I talked about the VP shunt, ventricle peritoneal shunt, that they could have to get placed to drain the cerebral spinal fluid off the ventricles. Pituitary dysfunction. We're going to go into greater detail with pituitary, there's a few things you need to know, but with pituitary tumors and TBI, actually, you have to monitor for diabetes insipidus. And I don't know if you've had this before, so I'm just going to tell you it's got nothing to do with diabetes mellitus. Diabetes insipidus means that there's no ADH. Okay, so the ADH has been stopped, okay, from being secreted. So the patient is going to start putting out copious amounts of urine. I mean, you are not going to be able to keep up with emptying a Foley bag when somebody has DI. It's just amazing how fast this goes. So you have to make sure you're giving fluids, monitoring I&O, daily weights, measuring urine specific gravity, okay? It'll be low, and don't restrict fluids, all right? And this is just showing you some types of treatments, okay? And this is, again, is phenytonin and dexamethasone. So steroid side effects you already know. So let's go to the treatment. Okay, phenytonin, there it is again. Remember the normal, well, you don't have to remember the normal anymore, the normal level, because it'll be on your exam. This is just telling you the side effects again, the gingival hyperplasia, use alternative birth control. I don't know if you've seen this mnemonic before, but that's kind of cute. Okay, all right, so if you're giving it IV, okay, you have to give it slowly at 50 milligrams a minute. The reason is if you give it too fast, they're going to code, okay? They'll go into cardiac arrest. So don't give it in small veins. Give it in a big vein because it is irritating, okay? So you need to monitor the ECG if you're going to give it IV. And this is just, again, reiterating your seizure precautions. Okay, and this is a craniotomy, and I'm only going to go over this positioning. So if somebody has supratentorial surgery, elevate the head of bed 30 to promote venous drainage. And it's same for hematoma surgery. It's really the same for increased intracranial pressure as well. So head of bed 30, and you want the head and the neck midline or in proper alignment, because that's going to allow the cerebral spinal fluid to drain. With infratentorial surgery, you want them flat or 10 degrees, and that prevents pressure on the neck area. Okay, and if anybody that has brain surgery, craniotomy, monitor for DI and SI-ADH. We're going to go into more detail about SI-ADH for exam 2. Here's your pituitary tumor. So somebody, they do it they can either do it through the nose to take out the tumor, or they can do it in the gum line. I worked with a neurosurgeon that did it through the gum line. So just anybody with brain surgery, this applies to anybody with brain surgery, no bending after they have it. For this type pituitary tumor, if they have a hyposectomy, no blowing the nose. Test clear drainage for halo sign and glucose, no bending at the waist, no coughing. And no brushing their teeth. Brushing your teeth increases your increased intracranial pressure. Okay. All right. So, and then we have the degenerate neuro diseases. And I don't go into a lot of details with these. And the reason I don't is because some of them are not that prevalent. And I want you just to have what you need to know to be safe, pass the class, have a basic knowledge. If you end up going on it, working on a neurological unit, you'll learn more about these diseases. So the first one I'm going to talk about is Parkinson's disease. Lots of different causes, okay? The reason they have it is they lack dopamine in the brain, so it affects their extrapyramidal system. Now, this is important. Here's the triad that kind of, tips you off that somebody does have Parkinson's. They'll have a resting tremor, bradykinesia. Bradykinesia means slow moving. So they'll have slow movement, and they'll have muscle rigidity. They call this like cog wheel rigidity. Okay, so that's the triad, and that's important to know. So with Parkinson's disease, they have a masked face. Okay, so that means they don't really, you can't see emotion in their face. See how he's like forward like this? Okay, stooped posture. This puts them at risk of falls. They have a shuffling, short, stepped gait, and they have tremors, and they have a resting tremor. So when they're sitting, they have like a pill rolling tremor, and that's when they're sitting. They can be, I'm sorry, what I mean by that is at rest. Okay. And that just distinguishes it from myasthenias, not myasthenias, multiple sclerosis, because that's an intentional tremor. Like when they go to reach something, they have a tremor. All right. So you're going to need to know, here's just a mnemonic if you like mnemonics better. Okay. But remember the triad. Okay, so the Parkinson's disease, you're going to have to know the classifications of drugs and just a couple of things about them, okay? So the classifications include the MOIs, anticholinergics, levodopa and carbidopa, and dopamine receptor agonists, and amantadine, okay? So with sedulene, okay, remember with the MOIs, this is important. You can't, patients can't eat certain foods like the cured meats, the hard cheeses, the Chianti wine, anything smoked, processed food. So just remember that. Um, and that's important. Okay. Oh yeah, I have it right here. Here's the foods they need to avoid. So usually ATI will give you something like cottage cheese, but that cottage cheese they can eat because that's a soft cheese. They try to trick you. Pickles, yeah, fermented foods. So know that. Okay. Now with multiple sclerosis, okay, this is an autoimmune disease and it results in a loss of the myelin sheath. Kind of like older adults start to lose their myelin sheath. That's why they don't have good reflexes, like they get really slow. Okay. So the findings in MS are going to be you can use Watson, the mnemonic, weakness, ataxia, tremor, speech, optic neuritis, and nystagmus. Now remember, nystagmus is that involuntary movement of the eyes. That can also happen when somebody has an adverse effect to phenytonin. So it's treated with steroids, okay, and it's a chronic disease. So with people with MS, their symptoms wax and wane. So they have exacerbations and they have periods of good time. All right, Alzheimer's disease, it's slow, it's on its onset and it's progressive. All right, so they're going to have a loss of memory, aphasia, so they can't express themselves, anomia. So the main thing with Alzheimer's is just keeping them safe. And then ALS, this is Lou Gehrig's disease. So they have progressive weakness of voluntary muscles, difficulty swallowing and speaking. So the reason I'm this isn't that prevalent either, but you just have to know a few things. If somebody has ALS, they're going to have respiratory problems and they may eventually need a mechanical ventilator, but because they have progressive weakness and difficulty swallowing and speaking, you have got to, watch out for aspiration. Okay, so that's important. Okay, Guillain-Barré, this is like really rare, okay? But for some reason, it's still tested. But how the question will go, you'll get some, maybe a college student or somebody young that either had like a flu shot 6 weeks ago or the flu, they had some recent sickness, and they come in complaining of peripheral nervous system weakness. Like they have weakness, it's ascending. So it starts in their feet and starts working up their legs, okay? And you start to worry when it gets to the hips because the next thing is going to be the thorax. And what happens is a lot of these people with Guillain-Barré syndrome will end up on a mechanical ventilator. Okay, but it's a good thing. This disease, it's progressive muscle weakness, but it resolves. So they go on a vent for a little while, and they usually have a full recovery. Okay, so lower extremities and the weakness moves up the lower extremities within 24 to 72 hours. Okay, so we just do supportive care for them. So they may need a mechanical ventilation, but again, you want to prevent aspiration. That's your job. Myasthenia gravis. So this is the same thing. They're going to have trouble swallowing. So you want to make sure that you are checking their swallowing and suctioning them if they need suction. So make sure there's suction in the room. All right, so those are like a quick view of the progressive ones. So it's mostly about making sure people don't aspirate when they have these progressive diseases. And with the Guillain-Barré, it's temporary, so that has kind of a good outlook, so to speak. But you would suspect it if somebody said they were sick a few weeks ago, they come into the ED complaining maybe of numbness and tingling in their feet, but weakness, okay, ascending weakness. All right. So, what kind of questions do you have for me? Like, do you want me to go over anything else? Okay, have you watched the first couple videos? Do you have any questions about those? Nobody has any questions?
So is this everything that's going to be on the exam, or is going to be more stuff?
Well, this is the stuff I didn't cover on Tuesday.
Okay, so it will be the stuff that you went over on Tuesday plus today, correct?
Yeah, everything on your tracking calendar. So everything you see over here in the corner, TBI, increase intracranial pressure, spinal cord injury, stroke, seizures, back pain, brain tumors. With the back pain, I wouldn't worry about that. That's important for your proctor. There was a question on practice A about that.
Okay.
Yeah, all things neuro.
Thank you.
Okay.
You're welcome. But
Miss
definitely do those, do the Quizlets too. Yes, what were you gonna say?
Miss Cohen, I'm sorry, I didn't mean to interrupt.
That's okay.
I have a question. There's some sort of like neurotransmitter studies that are done in the brain. Is that something that we'll cover that might not be included in the exam or stuff, but I do want to learn to see those studies. Is that something that I would
No.
research or something we'll hit
You
later?
could, you could, if you're interested in that, you absolutely can research it. Do you know how to go to our library? Like our virtual library? You can get it through oh God, Blackboard, like in the somewhere on Black, I think it's in the up left corner. Do you know how to do like a literature search?
I don't think so.
Okay, so it's kind of like a Google search, so you could go there and you would use Sinol.
Okay, I have my Blackboard up, so I'm in the main page.
Okay, hang on. Let me get mine up.
Okay, thank you.
It may be under resources. I think I've seen something like that
Oh, it
under
is.
extra
Yeah, it's
resources
right
on
under here.
Blackboard.
Why don't I share my screen?
Oh, thank you.
Okay. Um, okay, so I'm gonna stop sharing that. Okay. Okay, do you see right here?
I see your
Do you see where
screen.
do you see my screen?
I see your mouse. Uh-huh.
Okay, so see right, hang on, right here. Do you see my mouse?
Yes.
Do you have that? College Virtual Library?
Okay.
Okay. And then you would click on that. And then you can search articles. You could probably put in neurotransmitters here and see what comes out. Now, I personally I would pick full text and peer reviewed, so you don't have to search through a lot of different things.
Full text. Okay. Thank you so much for showing me that. I was not aware that we had that.
Yeah. And there's also, there's a way, okay, so you can email a librarian, like if you're having trouble finding, if you're having trouble finding articles, you can
Mm-hmm.
email the librarian for help and tell her what you're searching for.
Perfect. Okay.
Yeah,
Thank you. Thank you, ma'am.
we have a really good library. It's just, your programs are so accelerated that it's hard to get anything else in than what you really need to know.
Yeah,
Like,
I kind of felt that because I already earned my associate in a different college, but
uh-huh.
all my courses were like expired, so I have to retake everything. And
Oh,
I
you
just
had to
felt,
retake everything? Uh,
I'm sorry?
you had to retake everything?
Yeah, I have to take like the anatomy, microbiology, everything requiring the clinical requirements. So yeah, but I had earned my associates for the RN in Texas, and there was just so much information. I remember it was a lot more information. I feel a little um, like it's been 10 years. I don't really remember everything,
Did you
but
graduate?
yes, I graduated.
You did? And so why are you in the PM program?
Um, because I never did my clinical hours, and
Oh, okay. I
mhm.
see. Okay,
So
some schools do that. Yeah, there's some schools in New York that are in trouble right now for doing that.
yeah, so
Um,
what I'm gonna do is I'm going to, and you know what? It wasn't even the school's issue. It was mine. I had young kids. I didn't have support, and I couldn't do
mhm,
the clinical hours because I was accepted into the program. Um,
right.
and all I had to do was meet everything and be at the hospital, and it just didn't work out. But because everything expired, I just had so much material, and sometimes when I'm going over the material here, I feel like some stuff does get skipped, and I know it's an accelerated program, so I need to do my own research because I'm looking to going into home health or hospice, and um,
Right.
there's a
So
lot of things.
my advice to you though, right now at this point in your education, would be to focus on what you need to do to pass NCLEX. And then
Okay.
once you get because I'm telling you, like, I don't have the luxury of teaching you everything, right? I can't. There's no
Hmm.
way. So I have to teach you what is going to be really pertinent to entry level practice.
Okay.
Right? Because if this is a difficult semester for the third semester students. It's very difficult and rigorous. So they're always, wondering, to do well, you got to just focus on what you're doing now. I mean, I think that's great that you want to look up other stuff, but I think for now, you should focus on, what's in front of you right now.
Okay.
Yeah.
Yeah, that makes sense.
Because, it does like, I'm going to tell you, I was a nurse manager for a long time, and I hired people who like interviewed well. Not that I didn't really care about GPA. I didn't really care, about things you did unless it was related to like promoting clinical greatness, like evidence-based projects or something like that. But I like to interview people and determine if they would be a good team member, like a good fit for my team.
Hmm.
I want to know if they're a team player. I want to know, if I think that they're compassionate for our patients. So that's kind of the thing I would look at.
Okay. No, thank you. I
You're
will
welcome.
focus on what I need to, and then
Yes. So
take one day at a
really,
time.
right, you have a lot of things. All right, does anybody have any questions about like autonomic dysreflexia? Did you get to like study that? I went over it.
I think Miss France mentioned it in class, and I
Yeah,
did take note of that.
yeah, because it is going to be a couple questions on that. Meningitis is going to be big, so make sure you like read over that case study, know those signs like the nuchal rigidity, the Kernigs, the Brudnitskis. Make sure you know all those signs. You know, like the signs and symptoms of it. That's going to be important. And just especially students get the whole brain thing mixed up. Like if you have an injury in your left side of your brain, they forget which pupil is going to be affected. So remember that, okay? That's an important thing. And don't get turned around with people that had stroke, right? If you have a left-sided stroke, it's the same thing. The pupil on the left side is going to be affected, and then you're going to have the right-sided weakness. So it's the opposite weakness. Yes.
So basically how to remember it is pupil same side and then weakness opposite.
Yes. But the term is for same, the term is ipsilateral, and opposite is contralateral. And I don't know why, but students get turned around with that. And remember
Can you repeat that? IPSI is what?
Say it again.
IPSI is what?
Ipsilateral means same side. So if somebody has, say somebody has an epidural hematoma, right? That's the talk and die hematoma, and it's fast bleeding, right? Because it's the middle meningeal artery that's injured. So if they have it on the left side, the injury on the left side, they're going to have ecchymosis around their eye, but they're also going to have a blown pupil on that side, on the ipsilateral side. That means the same side. And then nausea and vomiting, and then they could have weakness on the contralateral side. So just don't get the sides mixed up. I don't know, for some reason in exams they get mixed up, especially when it comes to like CVA or stroke, which whatever they're calling it, because they'll tell you they have a right-sided, right hemispheric stroke, right? And then so you have to remember that means left-sided weakness. So you don't want to put things on the left side. You want to put things on the right side and utilize their right side. All right. And remember, like feeding precautions. That's going to be a thing. I went over that Tuesday. So remember, review that. But autonomic dysreflexia, know how to prevent it. Know like the signs and symptoms of it and how to treat it. That's going to be an important one too. Do you guys have any questions? Yes.
How many questions will it be on the exam?
It's 70, all our exams are 75 questions. And you have, I think it's 80% application or higher, and 15% select all that apply. So like 12 select all that apply.
Oh, okay.
And there's going to be a case study. Do you remember in class when you did that first case study? I wrote that case study, and then I wrote the case study. It's like it's going to be. It's not exactly the same, but it's the same sequence. Like you have to recognize the cues, analyze the cues. Same thing you did in class.
Okay. Oh, okay. Thank you.
Yeah.
How about next gen?
Next gen, yes, there are next gen questions.
How many do you know?
I don't.
Okay, thank you.
Don't exactly know. I think, okay, so for this one, I wrote the case study. Okay, so and you'll pay attention, like make sure you're looking over your classroom activities, what you did in class. Okay, so like didn't you do like templates? Make sure you're looking over those and know the nursing implications of those tests. Yes. Yes.
I'm so sorry. I was clicking the unmute and I raised my I'm so sorry.